Uh, All right, so welcome in everyone to today's webinar. If you think work is bad for people with mental illness, then what about poverty, unemployment, and social isolation? My name is Daniela Labate-Caselli, and I am from NIAPRS. I'm going to be hosting Joe Maroney today and all of you for our webinar. Just real quick before we go into the content for today, NIAPRS is offering continuing education credits for social workers, LMHCs, and CPRPs, and you'll receive a link to an evaluation within 24 hours to the email that you use to register for today's event. We ask that you complete that evaluation and let us know which continuing ed credit you're seeking, and return that evaluation within 48 hours in order to qualify for your credit. The other thing we need you to do in order to get CEs for today is to make sure that you are in the Zoom room and with us for the entire time. Otherwise, you'll not be able to get your credit. We are going to get started in just a minute, but first I just want to introduce Joe. And I also want to let you know that since we're in the webinar platform today and not in the meeting platform, we can't see everyone and everyone's muted. But we do know that you can communicate with us, and we would hope that you will communicate with us by the chat box. And I see the chat box is hopping right now. Lots of folks coming in and saying hi. So we appreciate that. And we hope that you'll have a conversation with us in the chat box. Type in your questions as they come up throughout Joe's presentation today by using the chat box, and just make sure that you type your question in either to everyone or to hosts and panelists so that we can see those. I'll be keeping track of those throughout the presentation, and I'll be probably interrupting you, Joe, and asking you questions as they come up. So without further ado, I'm going to just welcome you in, Joe. Joe Maroney is a recently retired senior program manager for public policy at the Institute for Community Inclusion at UMass Boston. He's currently a contracted consultant and program director of an online technical assistance project for the Boston University RRTC on mental health and employment. So with that, I'm going to turn it over to you, Joe, and let you take it away.
All right. Thanks, Daniela. Thanks, Eileen, there behind the NIAPRS logo. Hi, everybody. I was telling Daniela before we started that actually I don't mind Zoom because I'm a bit of a misanthrope anyway, but it's harder for me to do training because when I do stuff in person, I can kind of wander around and connect with people, and Zoom training I think is more susceptible to people who do more traditional kind of lecturing than I do. So we always do the best we can, but that's why I sent NIAPRS, and you have access to all the slides and handouts. I'm not going to go through each in handouts, but I'll tell you what they are. And because of the time, we don't have the time, and a lot of it is a lot more detailed. But anyway, I'm glad you're here. I know some folks I see from the chat box I'm familiar with, and it's kind of the same stuff as I told them. I was when Daniela called me up a few months ago and asked me to do this, I told her, and I was only half facetious, and actually probably only about a quarter facetious. She said, we can do either 60 minutes or 75 minutes. And I told her basically doesn't matter that much because I kind of say what I'm going to say in the first 5 minutes, and then I keep repeating myself. So, and you'll see what I mean later on. And in service to that, I added a couple of new slides as kind of a quick, here's the things I'm going to be repeating myself about. So I hope you folks will enjoy yourself. I hesitate to call this training because when I think about training, I think about particular skill development or a particular new knowledge. I'm not sure. There'll probably be some tidbits here, but what I'm basically going to talk about is stuff in a sense that people claim they already know, but don't always do much about. So that's what we're going to be focusing on. And it's certainly not going to be skill development because you're really going to have to practice and spend a lot of time to really hone on skills. And plus, the other reason I don't want to focus so much on specific skills is I think one of the problems when we talk about employment and mental health over the years is that we focused a lot at the line level and how, in fact, do staff do a better job on helping people with mental illness get employment. And that's a need. That has been a need. That's still a need. The ability of staff to develop their competencies and really helping people access employment. But I think what I know, and not that I think, what I know has been underappreciated is the fact that we're really talking about kind of system change and administrative change. We're not just talking about funding a particular program like IPS. We're not just talking about staff doing a better job of reaching out to employers, both of which are necessary. We're really talking about a whole different mindset and a major system change, not just around policy and funding, but about the whole way we conceptualize recovery and mental health systems of care. That's what we're going to be talking about. The title, if you think work is bad, blah, 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 actually came about from an article, which is one of your handouts, which I wrote with a friend when I was living in Boston over 22 years ago now, I guess. And I would probably write a little bit different now, although the tone would be roughly the same. And it came about because I used to do a lot of stuff with I was working for vocational rehabilitation at the time in Massachusetts, what you call VESID in New York State. And I would do a lot of linking with people from the mental health system, both clients and staff. And they would spend a lot of time, and people in my agency would spend a lot of time worrying about the stresses of employment and not moving too quickly and making sure people don't fail too often. All things which are certainly worthy of thinking about. But they didn't spend a lot of time thinking about how does work counter some of the real issues that people are dealing with. And one of the themes that I'm really going to harp on today is not just that it's important to think about work and people with mental illness and some of the benefits of work, but in a sense, more importantly, to understand that long-term unemployment is perhaps the most salient clinical risk factor that staff and administrators in the mental health system do not spend enough time thinking about as a clinical risk factor. Not so much that work is good, which it often can be, but not always, but that long-term unemployment is real bad. So that's what you're going to hear a lot from me today. And, excuse me. What I added, and I can send these slides, but you don't have yet. Here's the, what I talked about, I'm going to say what I'm going to say in the first 5 minutes and then repeat myself. I decided to add this slide. And underneath where it says the most effective marketing strategy in business ever, if you read the business literature, people often say that the most effective marketing strategy and marketing approach that's ever been developed has been one for shampoo. And if you read the instructions on the shampoo bottle says shampoo, use, rinse, repeat. And that's basically doubled the use of shampoo and the increase in shampoo use in the United States. So something as simple as that kind of repetition has really been seen as the most effective marketing strategy. So really over the next hour or so, I'm going to be talking about a lot of things, but they're essentially summarized. There's going to be a few things that aren't here, but in these 10 items. Number one, as I said, that unemployment is worse for you than any job is good for you. Some jobs can make you crazy, and not every job will help you. So it's real important to understand that we're not talking about no matter what you do for a job will always be useful, but rather avoiding long-term unemployment is an important clinical issue. Related to health overall, you hear a lot of talk these days about social determinants of health, which I have just abbreviated here as SDOH. And you hear a lot of talk about employment as a social determinant of health. And I would see it more in the reverse, that long-term unemployment is really a social determinant of ill health in a lot of ways. As I said, if we're going to talk about employment, I think it's important to take it out of what does staff say to clients or how do staff deal with people in terms of helping them get employment. That's an important factor, that it's a clinical responsibility. It's a value-based issue, but it's as much of an administrative responsibility. And I'll mention one of my jobs, I live in Portland, Oregon now. I spent most of you can't see me probably now as much, but I have my Lemoyne t-shirt. I went to college in upstate New York and Syracuse and worked there for a couple of years. Spent most of my adult life in Boston. And then because my wife's from Michigan and hated Boston, we moved out here to the West Coast, to Oregon, over 22 years ago now. And when I moved, I took a job as the deputy director of at the time, it was the largest mental health center in Washington State. And one of the issues that I dealt with was, how do I make sure that people understood employment as a part of the administrative value base and part of the administrative policy and part of the administrative goals of the mental health center. It wasn't just an issue of talking to staff about employment and recovery. It was an issue of structuring the whole mental health center around employment as a key issue and about unemployment as a clinical risk factor, which meant when I went there, even though I was over basically all the clinical staff and the residential staff, luckily I had a good employment lead person. And so we actually moved our employment staff up. When I went there, we had 3 employment staff. And when I left after a few years, we had 26 employment staff. But in terms of my work, I spent most of my time actually not with the employment staff, because that was being well attended to, but with the doctors, the nurse prescribers. Some of the best discussions I had about employment were with the crisis team. I made sure employment was something that was discussed at every executive team meeting every week, that every board of directors meeting, we had a report on employment. So I really made sure that it was seen as an administrative issue, not just a clinical issue. And I'm looking this, I have a typo, I did it quick. Forgive me, I yell at other people. As you can see, responsibility is spelled wrong. I should have checked that. Because it's an administrative issue, we're not just talking about increasing staff skills around employment and motivation and things like that, but we're really talking about how do you affect system and organizational change at all levels. I think when I think about employment, recovery, and citizenship as inextricably linked. I really think that employment is part of recovery and is part of citizenship, but I'll talk more about that. I believe, and I would assume most people who are involved with IARPRIS, at least in public, let me say, agree to the importance of person-centeredness and consumer-controlled treatment of services, that the client is at the heart of what we're talking about, and the client has to make the important decisions about his or her life. But that does mean that staff still have a responsibility to influence people. I was doing this once in another state, and it was at a consumer conference, and I was talking about this, and a couple of people got up very irate and said, it's not your job as a staff person to influence me. It's your job just to listen to me. And I basically vehemently disagreed. There's no reason to pay staff to have staff in a helpful and supporting role unless people seek to influence people. That's your job. It's not your job to control people. It's your job as a staff person to influence people. There's been a lot of discussion about motivational interviewing, and it's a wonderful technique. And there's been a lot of training, and I think most people in the mental health and behavioral science world are basically, if not fully competent, are certainly conversant with the concept of motivational interviewing. I talk about, and you'll see more, and I have a little slide that's in the handout, about creating a motivationally enhancing environment. One of my concerns about just focusing on motivational interviewing as the skill set is that even though it's a very helpful, useful, positive way of interacting with people, it's still predicated on the major change having to come from the person, him or herself. And my view is that the change in a lot of areas, but in this case, we're talking about employment, has to not just come from what the person does, but what the organization and the system around the person does. So that's why I talk about creating a motivationally enhancing environment. A lot of people, when we talk about employment, have made employment synonymous with IPS, individual placement and support, which, as most of you probably know, is the most heavily researched tool showing how to be successful in supported employment with people with serious mental illness. And next to probably assertive community treatment, it's probably the most well-researched mental health intervention over the last 30 years or so. IPS is a wonderful tool, and it's an important part of employment, but in and of itself does not deliver an employment focus within the mental health system of care. Basically, there is a very imperfect relationship. If you look at state data and you look at system level data around how successful people in mental health systems of care are in seeking and getting employment, that there's a very imperfect relationship between IPS programming and the overall ability of the system to help people achieve employment. So what you see is that IPS programs, in fact, do better supported employment than programs that don't adhere to the principles of IPS. But the goal of institutionalizing IPS is not just to help a few extra people get jobs, because the numbers are still small. The goal of IPS is to affect a change about how mental health systems of care view employment and support people in employment. And it's been much less successful in that in terms of overall system change. And I'll show you some numbers. I'm going to focus on New York State as well as national to show that. Clearly, there's an important element of data collection, focusing on outcomes. I was talking to Daniela a little bit earlier about the buzzword now is talking about value-based purchasing, which is kind of the current innovation of what used to be performance-based funding, milestone payments, pay points. It sounds good. It's a good statement to say values-based purchasing. The key, of course, is to say, well, what's the value you're purchasing? In some situations, the value you're purchasing is getting access to more people. In some situations, it's getting more people employment. In some situations, it's keeping more people out of the hospital. So just to say we focus on value-based purchasing doesn't help you solve the issue about how do you fund structures that really help people improve their lives. Now we're dealing in the real world. So I had a friend who used to say, sometimes you can only do the best you can do, not the best that can be done. And that's very true. But when I talk to people, I like to add a but to that. So what I tell people is that sometimes you can only do the best you can do, not the best that can be done, but it's important to know the difference. The reason why that's important in terms of mental health systems, particularly, or for that matter, dealing with people with disabilities overall, is that often when we don't achieve this kind of success we want to achieve in certain areas, in this case, employment, with the people we're trying to help, often the assumption is the problem are the people are too sick. People are very significantly disabled. People are impaired. Some of that's true along the way, but we need to begin to think about if we're not doing the best we can do for whatever the limits are, whether it's because there's not enough funding or there's not enough staff or we don't have enough support, all of the things which may be true, we can't hide behind those things and then say, well, that's the way it is. So it's important to say that even if we can't achieve perfection, and you've heard the phrase, don't let the perfect be the enemy of the good, and I'm a big proponent of that, understand that when there's a difference between that, we have to be clear about what the difference is between what we hope to achieve and what we have achieved. And finally, particularly when we talk about societal views towards people with mental illness, including but not limited to employment, they spend a lot of time about stigma and not enough time about discrimination. I'll talk a tiny bit more about that, but let me just say, and some of you may agree, some of you may not agree, here's my basic view of the world. I don't really care about stigma. It's a free country. People can believe what they believe. They can stigmatize who they want to stigmatize. What I don't want to see is discrimination. That is, I don't want people's behavior to operationalize discrimination against people, whether we're talking about employment or housing or any other kind of community access. So I think we're best served, not just, but including in employment, for focusing much more on dealing with discrimination than lots of anti-stigma educational campaigns. Here are the handouts you have. Some of them I'll talk more about than others, but I just want to let you know what they are. There's a whole set of handouts that I've labeled the Barry Selleck tips. And that's basically from two of my good friends of mine who some of you may know. Paul Barry is a person who used to be the executive director of one of the best community psych rehab programs in the country. And one of the early programs, more or less, started a little later than Fountain House, but came out of that same movement, but didn't become a total clubhouse, and became it was called The Village, and became basically a total, if you will, wraparound service delivery for people with mental illness in Long Beach, California. Paul was the former executive director. And what was interesting in terms of these kind of programs is before he was executive director, he was a director of employment services. And it was fairly rare for a person who came up from the employment arm to then become the executive director of a large psychosocial rehabilitation agency that's basically part of the Mental Health Association of Greater Los Angeles. He's retired now, and he put together basically a set of what I call tip sheets, both for staff and administrators, around how should they view employment and how should they help people seek employment. Virginia Selleck, who many of you know, is a good friend of mine who used to be the deputy director of another bellwether psychiatric rehabilitation program in the country called Thresholds, which really did start with around the same time as Fountain House, or of the same growth period of Fountain House in the 1950s. And Thresholds is based in Chicago. And she was the deputy director for a long time. And Gary Bond, who some of you may know, I certainly know of his work in IPS and ACT, actually, if you will, got a start in the field of becoming the research director at Thresholds. Virginia, since Thresholds, has worked in various arenas as the clinical director for the state of Missouri. She's worked a lot, does a lot of consulting now around basically recovery, a lot to do with employment, a lot to do with funding. And she's put together a couple of surveys about kind of ways to connect with non-employment staff about employment and the ways for organizations to begin to think differently about employment. And you'll see them, and they're both in the handouts. I put them together in one large PDF. There's that original article that I mentioned that the title of this seminar comes from, called "If You Think Work is Bad for People with Mental Illness, Etc." And that was written in, I guess, 1999 or 2000 now. There's an article I wrote more recently with Peggy Swarbrick, who a lot of you know, who's works for Rutgers, a woman who's an occupational therapist and also self-identified person in recovery, who spends a lot of her time now talking about wellness and people with mental illness. And she and I wrote this article together talking about the importance of employment and unemployment and looking at social determinants of health. There's another relatively recent article talking more from a policy end about mental health policy around employment that I wrote with Marianne Farkas, who's Director of Technical Assistance at Boston University on the Research and Training Center on Mental Health and Employment. And another friend of mine by the name of Larry Abrams, who's from Maryland, who used to work at a large program in Maryland. And it was really one of the chief advocates, certainly in that part of the country and nationally, around employment as an important part of mental health systems of care, and does a lot of consulting around the country, works with IPS, and also has done some work in the area in DC as well as Maryland. And finally, there's an article I wrote a few years ago with two colleagues of mine, Stephanie Taylor, now dead, unfortunately, died a few years ago. She was the former director of vocational rehabilitation in Oregon, and is one of the states, actually, Oregon is one of the states where, unlike in some areas, and I would probably say New York State is one area of this, where mental health has been trying to pull the vocational rehabilitation or New York State vested farther along in terms of this effort to employment. Oregon has been one of the states, and frankly, Delaware is another state, and I know there's some folks from Delaware, where the VR system has really been the point person trying to move the mental health system much further into employment. And Stephanie was the director at the time who really did a lot of that. And Bob Burns, who's now retired, another friend of mine who used to be the longtime director of Maryland Vocational Rehabilitation, who's instrumental in really some of the early bellwether partnership between Voc Rehab and mental health in Maryland that a lot of people point to as one of the best examples of interagency collaboration. And at the time, what was called braided funding. It's now called sequential funding as we move the lingo along. And that basically talks about some of the issues in terms of mental health and vocational rehabilitation partnership. So those all you can read at your leisure. You'll see a lot of quotes interspersed. I don't do inspirational quotes. Lily Tomlin, who's one of my idols, said no matter how cynical you become, it's never enough to keep up. And that's sort of the way I am at this point in my life as I move into my dotage, if you will. And here's my contact information you have on the slide. So as Daniela mentioned, I spent a long time working at the University of Massachusetts, Boston, retired a couple of years ago, still do some stuff there. I do a bunch of consulting now with Boston University and one of their research and training center projects, doing some online technical assistance around employment system change. I do some other stuff in places like California, Louisiana, Texas, Minnesota. But that's my contact information. Feel free to call my home office phone, my cell phone, and my email. We're talking about employment. I'm not that shallow to think that work should be the most important part of life. I hope all of you have other parts of your life other than employment. Hopefully employment's one of them that's reasonably satisfying. But I hope all of you have other parts of your life that are not just dependent on employment. Family, friends, pets, spirituality, recreation, hobbies, whatever. So it's not that I think work's the most important part of life. But work's what we're talking about. And we're not talking about productive role engagement. I really bristle. I'm working with another state, and I was working with the State Mental Health Advisory Council, and they called me up about talking to them about employment, except they don't talk about employment. They talk about productive role engagement. That's fine as far as it goes, but let's talk English here. Let's talk what we're talking about. We're talking about employment. We're not talking about productive role engagement. There's lots of ways about being productive in life without being employed, but we're talking about employment as one way. But so work's the most important part of life that I think in general, we in human services and particularly mental health systems of care do the worst at. So it's not that you should worry about employment more than anything else. It's that employment is and I'd say I've basically been in the business for 45 years. And we've made incremental but not substantial progress in understanding employment and avoiding long-term unemployment as a key part of mental health systems of care. So if there's nothing else you get out of our little little over an hour today, hopefully you'll think about how do you, in whatever roles you exhibit in the system, or if you're a client of the system, how do you begin to understand and work against long-term unemployment as an important clinical risk factor? What I tell people, and I believe in, as I said, when I was a director of the mental health center, when I do consulting, when I worked in vocational rehabilitation, when I give talks, that not dealing with long-term unemployment when you're in the mental health system, when you're an administrator or a staff person in the mental health system, is clinical malpractice. I can't put it any more directly than that. If you deal with people who have been unemployed a long time and you don't see it as a clinical risk factor that you need to do something about, then you're not doing your job. If you're a client in the system and you've been unemployed a long time and you're not struggling at some level with, how do I get out of this dilemma of long-term unemployment? You're basically putting your own limits on your life that you shouldn't be putting on. You know, I'm overstating it at some level, but that's where I'm at. That's one of the things I want you to think about. Obviously, if we're talking about employment, you can't just focus on nuts and bolts, but you have to at some level focus on nuts and bolts. So Thomas Edison said, results have gotten a lot of results, and several thousand things that won't work. And unfortunately, in the area of employment, over 40 or so years, we know lots of things that don't work very well. And even the things that work well, like IPS, don't work well at a level we can just be comfortable with. Here's the numbers. The latest figures that we have from SAMHSA. A lot of you know SAMHSA is the federal government that controls most of the funding for mental health systems at this stage comes from Medicaid and from state sources, but SAMHSA provides what's called the mental health block grants and other money. And as a requirement of that money, states have to report on employment. And basically what they report on is in any given year, what percent of the clients using the adult mental health system have any employment? So it's a pretty narrow element. It doesn't measure who's gotten employment. So for example, if you're a mental health system that provides a lot of outpatient therapy, in that case, you're probably dealing with more employed people. So it's not, your figures are higher, not so much because you're doing a better job with employment, but because you allow more people who are employed to access the system. If you're a mental health system like many are that only work with people with what used to be labeled severe and persistent mental illness, who have had a lot of problems with being in and out of hospitals, who may have been homeless, who may have co-occurring disorders like substance abuse, then you probably have a fewer numbers of people who are employed entering the system. So here are the numbers, and the last figures we have are through FY20. And by the way, for those of you who are knowing that the pandemic lockdown started in FY20, these numbers have not changed significantly from the 1990s to now. So basically what SAMHSA reports is that in FY20, less than 25% of clients in the adult mental health system have reported any employment. That figure is up a little bit from the year before, but it's still low. New York State actually, comparatively, compared to some other states where that figure might be 10%, 12%, 18%, basically is parity with the national figure, 23.7%. So if you're comfortable with 3/4 of the people you serve are basically not employed, then you're comfortable with this figure. I'm not comfortable with that figure. That's basically saying that 3/4 of the people we serve are essentially in a state which is increasing their risk factors for lots of other physical and mental health problems. It's not a straight through line because these numbers are not necessarily collected well, but the figures don't lie in the sense they've been fairly consistent nationally over decades. So basically we're talking about long-term unemployment being a basic demographic factor with people who use public mental health services. And if it's a basic demographic factor, then we're saying that a large chunk of the people we serve are basically increasing their risk for long-term physical and mental health. There's another factor, another statistic called basically in the labor force, and that's essentially trying to measure who's either working or looking for work. New York State actually outperforms the national figure. The national figures are a little over 47%. And supposedly in FY20, a little less than 60% of clients in New York State were either employed already who used the system that year or were claimed to be looking for work. Once again, that's still a big chunk of people who aren't. There's another number which people trying to look at access to various evidence-based practices. And one of them is IPS. The national figure that less than 2% of people in the adult mental health system have access to what's called IPS, evidence-based supported employment. That figure in New York State is much less. It's not 2%, it's 0.2%. Now, once again, there's a lot of controversy about how accurate these figures are. But if nothing else, they're accurate in the sense that every state has to report on the same things. Not every state does a good job of reporting on it, but it has what we have. So the question for you, and I know there's people from outside New York State, but since it's not, it's a New York State sponsored webinar. So one question is, for you folks, how can things like PROS, and for you non-New York State people, PROS is basically their Medicaid system with labeled personal recovery oriented services. IPRT, which developed years ago after some training from Boston University, which was essentially psychiatric rehabilitation programs, essentially day program, or a lot of them have unfortunately morphed into more traditional day programs, although I know New York State is trying to work to improve that, and psychosocial rehab programs, which a lot of states fund. So how can you do more through those elements, even if supported employment particularly, or employment particularly, is not a specific funding stream? How can you use the existing clinical funding streams to support employment? And as I said, sometimes you can only do the best you can do, not the best that can be done, but always know and state the difference. Do not assume that this 25% or this 23.7% figure of employment in FY20 is basically the limit of what you can do, and that 76.3% essentially documents the problems that clients possess that they have to deal with themselves.
Joe, can I interrupt you for a minute?
Sure.
So there's a lot of conversation in the chat box about funding and how critical funding is to ensure progress. And I'm wondering if you could, excuse me, if you could speak a little bit about how folks listening today could advocate for funding for employment services.
Let me tell you, I went to school at a place called Lemoyne, which is a Jesuit small liberal arts college in upstate New York in Syracuse, who some of you in New York might know about. So because I went to a Jesuit college, there was a lot of stuff about philosophy. And there's a lot of talk in philosophy about what's called a necessary but not sufficient condition. And what I found in my work around the country, and to some extent internationally over many years, is that the lack of funding for employment inhibits effective service delivery. I know have worked with and know a lot of states that have plenty of funding for employment that still don't do good employment. So it's important to understand that. But in terms of the advocating for, there's several ways. Number one, some states, in fact, do develop funding models that include employment. And you know, it gets very technical about Medicaid and stuff. But for example, I'm working with Washington State, which has what's called, which a lot of you know some of the lingo, 1115 waiver, which essentially says you can try lots of innovative things as long as your Medicaid costs don't go up. They specifically wrote in their waiver to include employment. So there's a specific funding stream within Medicaid, within Washington State, and some other states like Oregon, that allows you to fund employment. So the mental health system can actually provide employment services directly and fund it by billing Medicaid or billing, sometimes it goes through the managed care system. But anyway, that's one area. A lot of states that use mental health block grants or have state line items for funding advocate for the state mental health authority to develop a specific funding line item for employment. And you have to look at your own state to say, does that exist? What's the possibility? Obviously, when you talk about that kind of advocacy, but that's a possibility. The downside of that, for example, Massachusetts years ago said we wanted to not deal with the Medicaid problems around employment because unless you do a specific waiver, Medicaid can't fund generally job development or job skill training, although they can fund other things, which you can talk about. However, the state of Massachusetts created a budget line item for employment to fund mental health providers to do supported employment. The good news was they created their own rules at a state level and weren't inhibited by federal Medicaid rules. The bad news is that when the budget crisis hit, they eliminated that funding. So that's the downside of creating a state line item for funding, but some states have done that. I think what I find with a lot of states that's underutilized is that there are, let me just mention, once again, I hesitate getting into too much technical stuff because it really comes down to what you can do at a state. What's been developed over the last few years is what's called a 1915I part of a state rehab option. Traditionally, the state rehabilitation option, which funds most community services like psychosocial rehab or community support, does not include funding for employment because of the state Medicaid rules. There is a model called 1915I, which essentially replicates a lot of the kind of funding you can do through a waiver to actually specifically support employment under the rehab option. There's some technical issues around that many states thought originally this would be the way to use Medicaid to fund employment. But for a variety of technical issues having to do with rules about not creating waiting lists, having to come up with a target group, statewide approaches, that has to be offered throughout the state. Many states have moved away. For example, Oregon, which originally funded a lot of its supported employment through this 1959, have changed it to what's called the 1115 waiver. The other option, though, and all those, you can find a lot of information nationally and probably in your state about waiver services, Medicaid, things like that. The part that I find underappreciated in terms of, and those changes, if your state wants to change its Medicaid rules, if your state wants to apply for a waiver, things get very complicated. States have done it, lots of states do it. But at an advocacy level, you have to understand that it's not just a question of saying, let's get these Medicaid options to fund employment. It has to do with a whole policy change that involves the legislature, that involves the state Medicaid authority. So you can advocate for it, but understand the complexity of it. The part that I find underutilized in funding is the existing funding streams. Most states in community mental health, whether they're in managed care or they're in a straight fee-for-service, fund something like psychosocial rehab, community support services. They're called different things. But essentially, they're funding clinical supports to help people maintain themselves in the community and deal with quote-unquote medical necessity, to deal with people's mental health issues that might interfere with them maintaining themselves within the community. Almost all those state-level funding sources, and you'd have to look at the particular rules, if you will, within reach. Almost all those things which don't technically fund employment allow clinical staff to fund the kinds of clinical things related to employment that is short of job development and job skill, like training people to be an accountant or a teacher or a packager at a factory. So one of the things, and actually I could send, I'd be happy to send Daniela some stuff on this, and because it gets more detailed. But essentially, one of the funding sources that don't require any changes at a federal level, it does require some ability to discuss this with the state Medicaid authority, the state healthcare authority, is to use the existing community support psychosocial rehab funding in conjunction with people seeking employment, which may be funded, say, from Voc Rehab. A lot of states use this joint funding with vocational rehabilitation. So a simple, I don't want to say simple, a more common kind of approach would be using the existing authority, not the waiver necessarily, but existing psychosocial community support funding for clinical staff to help people do, you might call it vocational self-assessment, discovery. What do I want out of life that work can help me with? That would be funded through the clinical funding. Voc Rehab can help people fund the specific job development. In some states, the mental health provider is actually a vocational rehabilitation community provider too. So the vocational provider can fund that employment provider directly with vocational rehabilitation funds. In some states, it's a employment provider that's closely coordinated with the mental health provider. Then at the point where someone gets a job, some states are able to basically fund using, say, mental health block grants or something like that, a bonus, if you will, to the mental health provider for that person being working. The vocational rehabilitation can often then fund the upfront support to help people make sure they maintain themselves in a job. Traditionally, it's although there's no strict time limits, traditionally it's about a 90-day period that vocational rehabilitation can fund those kind of upfront supports. And then over the long term, the clinical supports provided by the mental health authority through the existing psychosocial rehab community support provider supports. All those things get complicated, but require a whole kind of discussion in themselves. But those are the various models of funding that people can use. What I find is that, particularly at the level that I talked about with psychosocial rehab community support funding, it's not an issue of changing any rules. It's an issue of understanding how to make sure you connect the kind of supports that help people with employment connect to what you all know as medical necessity. And as I said, I'd be happy to send Danielle some stuff on that. And Danielle, if you want to post it, or because it basically has to do with how do you define the kinds of supports you provide in employment in the context of clinical support. And that's what's often lacking. Not the support with job development. Some states, as I said, Delaware and Oregon, and to some extent Missouri, Minnesota, are states where often the vocational rehabilitation has really taken the lead on helping people in the mental health system get employed and linking up with the mental health system. In some other states like Washington, the mental health system, to some extent, has kind of worked around the vocational rehabilitation system, even though it's there. So you have to work that out at all the levels. But that's the different ways, and you have to look at the landscape in your state to say what exists now that we can use to provide the clinical supports for employment. Then are there changes, big system changes, like getting an 1115 waiver, advocating for a 1915I? Delaware, for example, originally in the mental health system, wanted to do what's called this 1959, just make it part of the state rehabilitation option. But they found it too complicated. Oregon did the same thing. They switched that to having the state change to a Medicaid waiver. But if you're a mental health provider, you really can't control what the state does about their overall Medicaid plan. You can certainly advocate and say, hey, look at what Washington has done. Look at what Delaware has done. Look at what Missouri has done. But that gets complicated. I think at the level most of us have influence on, what we can advocate for most effectively is using the existing funding that provides clinical supports for maintaining themselves in a community in a way that enhances employment. Almost every Medicaid regulation that has to do with community support services or psychosocial rehabilitation talks about one of the life areas that these supports are supposed to help are something like self-sufficiency, vocational well-being. And I think people are very narrow in their approach to how clinical staff can provide those kinds of supports. So I hope that helps a little bit. As I said, the actual ins and outs get somewhat technical. And I can send Daniela stuff I wrote for the state of Washington about medical necessity and employment that might be helpful in that.
That would be great. Thanks, Joe.
Okay. This stuff isn't easy. One of my favorite philosophers is me. And what I tell people that all change is difficult no matter how long you put it off. One of the problems of system change that we talk about is there's often all kinds of planning committees and work groups, and I'm dealing with a state that has talking about system change in employment, and they're dealing with work groups of 40 people. And sometimes you can get kind of seduced by the planning process and not enough with the change process. And one of the issues is that change is difficult no matter how long you put it off. I would really encourage people, this person does not write about human services in general. He's a well-known sort of business change guru, John Carter, and he talks about leading change why transformation efforts fail. And he has sort of 8 little tips, and it's in that article about leading change you can look up. But the 2 I want to mention most, the number 1, what I find is that people don't, when we talk about employment and system change, there isn't a sense of urgency. People see it as, well, something we got to work on, but part of the issue is practical. If you're in Albany, New York, and you're a mental health provider, and somebody who's in mental health treatment commits a violent crime, that's all over the front pages of the Albany Times-Union. Or is homeless. That's all over. The fact that 3/4 of your clients are unemployed doesn't make the newspaper. So the community often doesn't have a sense of urgency about employment. And it's only if we within the mental health system or advocacy system appreciate the importance of dealing with long-term unemployment. So one of the first parts folks need to do, whether you're talking about funding models, or you're talking about clinical training, or you're talking about kinds of services people provide, is really understanding dealing with long-term unemployment is an urgent clinical issue. There's lots of stuff in between, but that last one is important, is if you do begin to make improvements in employment, how do you make sure it's basically totally anchored in the organization's culture? How do you see it, not just as an ancillary service, but as a core part of a system of care? So one of the dilemmas what I find with even states and organizations that have embraced IPS is they remain what I call boutique services, and employment overall is not anchored in the organization's culture. The other sort of simple little way of looking at organizational change, this had nothing to do with employment. It was written, what's it now, almost 20 years ago, in a monograph about system change in around housing and homelessness. And it was written by the Corporation for Supportive Housing, which a lot of you know about, have heard about. And they talk about, if you're talking about system change, and each of these can be a whole discussion in themselves, you're talking about changes in power, how influential is employment and employment service delivery in an organization. Money, as we talked about, is there money for employment specifically, or are you able to leverage existing money as a way to support employment? Habits, how do you consistently engage with people you serve around employment? Technology and skills. Once again, I don't want to say this is the only thing because it's too often only focused on, but there are issues about if you're an employment provider, how good are you at engaging the employment community and helping people get employment, maintain employment, dealing with discrimination. And ideas of values. I kind of struggle with the value stuff because at one level, I think all this stuff about employment essentially comes down to how do you value employment and dealing with long-term unemployment as a major system change. On the other hand, it can't just be at the theoretical. It can't just be in mission statements. When people ask me to help them with a mission statement, I say, okay, let's take 5 minutes and we'll write a mission statement. Or go to Walmart and rip it off the wall. That's good enough. One of the problems I find with organizations is they focus too much on the ethereal and not enough about, if we really have this value, how does it show up? When I work in technical assistance and people say, we want some focus on employment, we want system change. One of the questions I ask people is to say, if this works, whatever this is, if this works, and I come back in a year not knowing what you did, how will I concretely see something different? So values without action don't really mean much. You can see my reminder. Once again, I'm talking about employment. I think being productive is a good human value. That's not the same as working. Volunteering might be a good strategy for people. I think it's very healthy for people who have been impoverished clients of a system to volunteer when they can and when they want to. It's not the same as employment. Employment is a different issue. Pat Deegan, who I know almost all of you, if not all of you know, she doesn't usually talk about employment so much, but many years ago in Oslo at a conference she spoke at, she talked about life lived within the confines of the human service and rehabilitation landscape is a life in which the freedom to become and make your own future is diminished. And that's what I'm worried about. Not saving money from Medicaid or from human services so much. I'm worried about people making their lives less, diminishing their own lives by remaining in a state of unemployment or being encouraged to remain in a state of unemployment. I really do believe, and this, once again, is worth spending more time on, but let me just say, I think if we believe that people, and I think most of us on this kind of webinar do, that people should not be defined by a mental health label. People should not be defined by their illness, by their disability. So that means if people can work, people should work. I think work is an essential part of recovery. It doesn't mean that the only responsibility is on the person to change their life. The responsibility is both on the person and on the people around them to help them change their life and to deal with the kinds of barriers that people face, like real discrimination, like transportation, like symptoms that may be hard to control. They're real issues why people don't work. But one of the issues is not people can't work. And if people can work, then I really believe people should work. You hear a lot of talk about benefits. There's a real issue with benefits and the underutilization of Social Security benefits. What I find is that loss of benefits in many surveys with people, I'm not just talking about anecdotal stuff, I'm talking about really asking a lot of people with a history of mental illness why they're not working. Worrying about losing benefits is an issue, but it's often not the top issue. Often the top issue, I'm worried about getting sick again, or I feel like I can't work. I don't believe I'm able to work. And that may come up because of bad experiences they have, or they lack trust in the people who say they're going to help them, like vocational rehabilitation or mental health. Conversely, when you ask staff about the reason why people don't work, almost always loss of benefits is the number one thing. So there is a disconnect between often when you ask people themselves on a broad level, not just an anecdotal one-to-one level, why they're not working versus what staff think. The concern with that, to my mind, is that if you say that the reason is benefits, then staff more or less throw up their hands and say, well, what can I do? There's Social Security rules. I'll refer them to benefits counseling. So it kind of eliminates the responsibility that staff have themselves. So physical and mental health mix of risks of long-term unemployment are often understated by staff. Once again, I'll nag you forever on this. Long-term unemployment is one of the major clinical risk factors that people with long-term mental illness face, and frankly is on a par with things like trauma, with homelessness, with other illness. Long-term unemployment is a major health clinical risk factor. Somebody asked me once, I did this kind of stuff, and this mental health, director of mental health in the state said, oh, I get it, I'm really behind employment. She called me up about a month later and said, I'm struggling. I had a meeting with our chief psychiatrist for the state mental health system, and he stumped me. He said, isn't it better to work 2 or 3 hours a week at something a person likes than 15 or 20 hours a week or more just to make a living? How would you answer that, she asked me. I said, no, that's simple. The answer is no. It's not better to remain unemployed and remain poor by working 2 or 3 hours a week. There's lots of people who use work as a way for fulfillment. There are also lots of people whose work is a way to make a living so that they can have fulfillment in other ways, by their family, by recreation, by hobbies, whatever. So I think it's important to not demean the importance of work and letting, if you will, people off the hook by assuming that whatever they do that feels good is just as good as working. Now, having said that, we deal with the real world. Not every job is good for people. Many of you, when I do this stuff in person, I ask people to raise their hands if they've ever been in a job that was a bad job, and almost everybody raises their hands. So there's nothing magical about work. That's why it's important to not just help people get employed, but in finding out for them what's important in employment and helping them do a good quote unquote job match, on connecting at some level their interests with the job. So it's not that work is the end all and be all. We all probably know people, if we're not people ourselves, who are working 2 or 3 jobs who are still poor. In our society, sometimes even jobs aren't a way out of poverty. It's certainly a better way out of poverty than assuming Social Security is going to help you out of poverty. But we're dealing with the real world. But the important point is that it's not that any job is good for you or better work. It's that long-term unemployment is a major clinical risk factor. This comes back from 1928. This is as close to inspirational as I get. I don't even. John Shedd wrote this book called Salt from My Attic, and he said, a ship in harbor is safe, but that is not what ships are built for. So that's my view, is that there are certainly risks sometimes to working. There are bad jobs. There are bad employers. There are difficulties in maintaining yourself even when you are working. But if we're talking about a recovery-oriented system of care, we're talking about help people achieving full citizenship in our society. And one of the roles of citizenship is being a worker. Excuse me, turn off. Once again, these are one of the things I want you to take, if nothing else. Remaining unemployed is worse for you than being employed is good for you, because some jobs are bad for you. Avoiding long-term unemployment is a better option than waiting for a perfect job match. I have, which for time I'm not putting, sometimes I actually put them up. I have it's now over 100 now, epidemiological studies between 1938 and 2021 that shows there's a strong correlation between long-term unemployment and physical or mental health problems. There's a ton of articles and studies. The best kind of summary is actually from 1987. A fella wrote this book called Work. It's a whole book, Work, Unemployment, and Mental Health. And the findings are that what are the side effects of unemployment in the general population, not just the population diagnosed with mental illness? What are the side effects of long-term unemployment in the general population? And these are all the things: increased substance abuse, reduced self-esteem, loss of contacts, physical problems, psychiatric disorders, alienation and apathy. These are all issues which, if I'm running a mental health system of care, I want to ask myself, do I want to be in a position where I'm basically not addressing these clinical risk factors? Because if I'm dealing with people who've been unemployed a long time, and I'd say, long is a relative term, but I would look at essentially looking at people who are unemployed longer than 3 months or so. I would say I have a responsibility to help deal with these risk factors. Otherwise, I'm not doing my clinical job. You can read the article attached that Peggy and I wrote about the detrimental health impact of unemployment. And essentially, it restates that and talks about how we can assume mental health systems should deal with it. Pat Deegan, once again, as you know, she's probably the most powerful speaker about mental health and having someone who have moved themselves through a process of recovery. She says it's nearly impossible to make your own future when you're not part of the economic fabric of the culture you live in. And then Ed Knight, who you all know, unfortunately not with us any longer, said, what drives me up the wall is the intentional teaching of fear of having any kind of meaningful life, because you will decompensate or you're stress sensitive. The most stressful thing in the world is being a couch potato with nothing to do, nowhere to go, and no one to talk to. So that seems to me obvious why we need to deal with it. But then we look at Rita Mae Brown, who many of you of my age may know about from the 60s and 70s. Her most famous book was probably called Ruby Fruit Jungle. And she said once, if the world were a logical place, men would ride side saddle. As I said, we know that IPS is perhaps one of is the most heavily researched intervention model for supported employment for people with serious mental illness. However, we need to think about not everybody needs or has access to IPS. So we need to think about other things like voc rehab agencies, what's called VESID in New York State. We need to think about using the workforce system, the one-stop career centers. We need to think about the basic labor market. There are lots of people with mental illness who are doing fine and need some clinical support, but can do work stuff on their own. The one-stop system, even though in some states it's not always been helpful, in a lot of states it's been very helpful to people with psychiatric and other disabilities in terms of accessing businesses and getting employed. It's often based on a self-service mentality, so sometimes the mental health provider has to provide the support using the one-stop center, but it's there. Many states, most states, I would say at this stage, use some element of vocational rehabilitation funding to provide some of the concrete job development funding around supported employment. So one of the issues, Edward Deming, who's sort of the godfather of quality management, said once, beware the continuous improvement of things not worth improving. One of the dilemmas we find in employment is, while there's been a certain amount of minimal increase in employment services and employment outcomes within public mental health systems of care, there's been a greater increase in non-employment services, in things that started out as community support, psychosocial rehab, that basically have morphed into more traditional day program without helping people live their lives more fully in terms of housing, in terms of relationship, in terms of employment. Sometimes when we talk about these general things, people say, well, I'm already doing it. And my response is, if you're already doing it, how come it doesn't get done? Because it's not happening in terms of employment. So what should clinical staff do? We're talking, let me look, 5 minutes here. Are there any other questions before I do my last 5 minutes, Daniela?
Nope, you can go ahead. Okay.
So what should clinical staff do? And obviously these are easy to talk about, hard to do. Really focus on recovery values and the social determinants of health and understanding long-term unemployment as an element of that. One of the things I did when I was a mental health center director was to make sure that employment was on all service plans as a default if someone was unemployed longer than 3 months. They didn't necessarily have to get someone a job because that might be what they wanted, but they need to focus on employment. The importance of using motivational strategy, which I talking about motivational enhancing environment, which you'll have in your handouts on the slides, which talks about how to create a system that provides motivation, not just providing one-on-one motivational interviewing. Provide both help and support. I think it's important to distinguish. Support is giving people what they want. Help is giving people what you feel they need. Sometimes people need both, but it's not the same thing. You need to be clear about, I'm amazed at the numbers of providers in mental health systems that don't track employment consistently among their clients. You need to see employment as a clinical support. You need to engage other sources of support, voc rehab, provider networks, peer support networks, advocates, families, workforce systems. If you're an administrator, there's lots of specific things you should do, but you need to understand it as a policy issue that needs to be handled administratively, not just clinically. It's not just a question of how staff operate. It's how you organize and fund services for employment. This is what you have in your handout, what I describe as a motivational enhancing environment. Paul Barry, who, as I mentioned, as one of those tip sheets, talks about invest as much time in someone who has started a potentially life-changing job as you would for someone who is having a life-changing crisis. And also, when, this is the obvious issue, when people are unsuccessful in employment, don't assume that's it. Oh, they've tried it, didn't work out. If employment's important and if avoiding long-term unemployment is important, then you keep at it because it's an important life-changing issue, just like relationships are. And obviously you need to, it's not just a question of valuing things, it's understanding that, as this Greek proverb says, before practicing virtue, first secure an independent income. As I said, I'm less worried about discrimination than stigma. What we know from stigma research is that most of stigma education or anti-stigma education is not very helpful. It should follow concrete information like helping more people get employed and then demonstrating that in terms of anti-stigma campaigns, rather than assuming that an anti-stigma campaign is the entry point to getting more people employed. As these writers wrote once in talking about competency assessment, you can teach a turkey to climb a tree, but it's easy to hire a squirrel. Once again, stigma reduction training has to follow, not precede, behavior change, because behavior change influences values more than values influence behavior change. As we're ending, let me just mention these things. Let me just mention these things. There's only 3 things that help people change. You got to give people a sense of hope. You got to give people some concrete help. And you got to hassle people. You got to make people uncomfortable with their current state. Hassling might mean booting people in the rear end. It might be putting your arm around people. It depends on your individual relationship. You can't hassle people without a strong relationship. But you need to provide those 3 things for an organization to change or a person to change. A sense of hope, some concrete help, and some hassling. And let me just end with this old Yiddish proverb, or 2 quotes. If one person calls you a jackass, ignore him. If a second person calls you a jackass, think about it. If a third person calls you a jackass, get a saddle. And finally, Mark Twain, who said, "You nothing can say in answer to a compliment. I've been complimented myself a great many times, and they always embarrass me. I always feel they have not said enough." So thanks a lot. I appreciate it. I'll send Daniela what I said, and you have those other handouts. There we are.
Yep. That's great, Joe. Thank you so much. Lots of good stuff in the chat box about thanking you, stuff about organizational change, really good, motivation for the folks listening on the line today. Just lots and lots of thank yous coming through. I, from NIAPRIS, would like to say thank you so much, Joe, for today. And for everybody on the line who's been asking, we are recording today's webinar, and the recording, as well as the PowerPoint and all of the resources and handouts, will be posted on the NIAPRIS website. So we hope that you will come by and check that out, and come back next month, for we've got a couple of webinars happening next month. Harvey just sent them out. We've got career chat, and we've got story circles, and we also have a webinar tomorrow evening at 5 p.m. on coercion. So you can register for those. You can go on the NIAPRIS website and see the links for those as well. So Joe, any last words before we sign off?
No, just appreciate it. And once again, I think what's most important is to think through not just what the person has to do differently, but what we as organizations have to do differently to make this more reality. But I appreciate Harvey and I go back many years.
Well, we thank you, Joe. It's great to see you. Thank you so much.
Thanks a lot, Daniela. Thank you, everybody.
Bye-bye, everybody.